Welcome to session 3. This is Eco in Intervention session. Here we have a chairperson with us, Professor Fazila-Tun-Nesa Malik, Professor Qamrul Islam, Dr. N.A.M. Momenuzzaman, Dr. A.P.M. Shorabuzzaman, Professor Muhammad Maksumul Haque, Professor A.Q.M. Reza, Professor Abdul Kader Akhanda, Professor M. Atahar Ali, Professor Amal Kumar Chowdhury, Professor Dr. Muhammad Shahabuddin Talukder, Professor S.M. Mustafa Zaman, Professor Muhammad Mamunur Rashid Sizar, Professor Ashok Kumar Datto, Professor Sayyada Professor Sayyid Alia Sultana, Dr. Anuruddha De, and Dr. Manish Banshal. And panelists for this session, Professor Dr. M.Badiuzzaman, Professor Mohsin Ahmed, Dr. Kaisa Nasrullah Khan, Dr. Pradeep Kumar Karmakar, Dr. Abdullah Al Jamil, Dr. Muhammad Shafiqur Rahman Patwari, Dr. C.M. Shaheen Kabir, Dr. Rasul Amin, Professor Muhammad Saidur Rahman Khan, Dr. Zaman, Dr. Kazal Kumar Karmakar, Dr. Mohsin Ahmed, Dr. Momenuzzaman Ahmed, Dr. Khondokar Zaman, and Dr. Saleh Nasrin. So here I invite my another moderator, Dr. Mustafirul Haque, sir. And another chairperson, Dr. Momenuzzaman Ahmed. Sir, please come to the dais. Now I would like to invite the first speaker of this session, Dr. Anuruddha De, who is the consultant, Department of Non-Invasive Cardiology, Apollo Clinical Hospital, Kolkata. His topic is role of echocardiography in percutaneous coronary intervention. Please, sir.
Good afternoon, everybody. Am I audible?
Yes, sir.
Yeah.
You can
My slides
proceed.
are visible?
Yes, sir. You can proceed.
So good afternoon, everybody. This is a very fascinating topic, actually, is given to me, and I'll try to do justice in the next half an hour. So echocardiography is very, very essential before, during, even after the PCI. Why? Because it's so accurate, it is rapid, it is non-invasive, and it allows repeat examination. See, the percutaneous coronary intervention, which we call routinely as a coronary angioplasty, is mainly done during the unstable angina, acute myocardial infarction, all in the multivessel coronary artery disease. As we all know, indications and PCI, mainly in the acute ST elevation MI, non-ST elevation MI, unstable angina, stable angina, or even in angina equivalent with the dyspnea, arrhythmia, dizziness, or syncope, or with the high risk stress test findings. However, it is equally important to detect any complication of myocardial infarction before subjecting the patient for PCI. If we go to the chart, a patient comes. So let's see a patient come with the undifferentiated chest discomfort or suspected ACS complication. We do a EKG and that shows STEMI. If so STEMI, then it indicated as ACS modification and protocol. And this tried immediately to the cath lab with on-table focus examination. If no, there is no STEMI. If there is a hypertension or is there any unclear etiology, urgent echo in the emergency room. There are three possibilities: either normal cardiac function, then investigate alternative diagnosis. If there is a regional valve motion abnormality, then proceed with the coronary angiography. And if you find mechanical complication, any mechanical complication identified, then treatment depends on the complication you see, and that type dictates your management. But if there is no hypertension, then again it goes to chest pain unit with the serial troponins. So echocardiography is of tremendous value in the stratification in MI and the unstable angina. It is helpful for assessment of LV function before angiography. All patients with echyma should ideally have early echocardiography. Patient with unstable angina, non-ST segment elevation MI, we know it is a heterogeneous group. And these patients are persistent with wall motion abnormality, have more severe chronic ischemia, are at higher risk of adverse event. Severe LV diastolic dysfunction tends to be associated with a large infarction, but a restrictive pattern is also independently associated with poor outcome. So what do we do before PCI? What is the role of echocardiography? It first important is the assistant diagnosis. Echocardiography will localize, demonstrating by localizing an extent of myocardial wall motion abnormality. Particularly important in those patients who are not obviously high risk. Many patients without clinical evidence of LV dysfunction will have significant wall motion abnormality. It's a very important point to note. Patients with extensive regional abnormalities should have follow-up echocardiography, and this may detect early LV remodeling and other complications after subsequent medical management. You also determine the diastolic dysfunction because it occurs before the systolic dysfunction. ECG abnormalities in chest pains are relatively late findings. Segmental wall motion abnormalities seen by echocardiography correspond closely with the coronary artery territories. And there is some variation depending on the dominance of the right coronary artery in the circumflex artery and the extent of the watershed areas. Look at these two patients, very important patients. These are two important young patients. In the first patient, you can see there is a definite echinacea, absolutely echiding anteroseptal wall. Is patient presented within 1 or 2 hours after the chest pain. ECG is unequivocal in both these cases, and the biomarkers is yet to rise. So if you get this type of patient, then you can definitely diagnose as a case of acute myocardial infarction. Here is the anteroseptal, and here is the infraposterior wall. So it can assist in diagnosis. Not only assisting diagnosis, it can detect any complication you find in myocardial infarction. Whatever is the complication, it can be detected by echocardiography. Here is a patient of the acute myocardial infarction with the papillary muscle rupture. You can see the hyperkinetic right ventricle, and you can see the thrash papillary muscle with a severe mitral regurgitation. Of course, in this case, the LA is normal in spite of having severe mitral regurgitation. You may detect pseudoaneurysm in a case of acute mitral regurgitation. You can detect the ventricular septal rupture. It is a story of a 45-year-old man with acute chest pain in the Hearst systolic moment. You can see there is an acute myocardial infarction, anteroseptal myocardial infarction. But when you look at the color, you can see absolutely at the apical region, there is a ventricular septal rupture. And you always focus throughout the septum to detect, because sometimes you will miss at the absolutely apical part. And off-axis view, you can find out even the great flow across the ventricular septal defect. And it's almost a 9 millimeter defect with the gradient of 52. But here is another case. Acute myocardial infarction presented with the severe cardiogenic shock, where what happens, the whole of the septum, apical part and mid part of the septum is totally washed away. And here is the trabecular band. And when you put the color, you can see the free flow between the LV and the apical part of the RV, only to restricted by somewhat by the moderator band. And that you can see in the next picture. And not only that, you may detect thrombus, even because that's a got prognostic value when I'll discuss it when we'll discuss the role of echocardiography in after PCI. So you can detect this type of thrombus, where it's like is hanging like a grapes, or you can detect the large thrombus bridging the two walls. We called it the thrombus bridge between the septal and the lateral wall. Then you can here is a story of another anterior in the lateral wall, MI. You can see, you may see some presence of some thrombus in the, maybe you thought it is a very small thrombus, but you must loop the whole of the left ventricle to find out what is actually happening. See, it looks like a small thrombus in a case of acute interval myocardial infarction. But when in off-axis view, we can see the thrombus is extending up to the almost to the brim of the mitral valve in the septal area. And when you short axis, you can see the thrombus is extending. And another view you can see even in going to the whole of the anterior wall. So it's basically is a carpet of a thrombus throughout the LV. So you must detect this type of things. Sometimes inadvertently, in a patient of the chest pain, you thought is a case of myocardial infarction, but it is actually a case of aortic dissection, and that must be ruled out before undergoing PCI. So, indication for PCI to detect, diagnose, and find out the complication of the myocardial infarct. Having decided that, you have to do the two important things before PCI. One thing is that whether this patient is having worsening left ventricular LV dysfunction, and that can be done only by the echocardiography and repeated echocardiography. And another important is the viable myocardium. The issue of viable myocardium, I'll give an example of this is a case. This is a patient of 42-year-old male. They presented with the acute myocardial infarction with the cardiogenic shock with a severe LV dysfunction, and the patient was immediately put on ventilator. And this patient was stable after almost 4 or 5 days. We could not do anything. Now is the question, before going to the PCI, whether this myocardium is viable or not. Can we detect even in the patient with the ventilator? Because this patient cannot be shifted to the nuclear medicine department to find out the SPECT or any other technetium imaging. Here echocardiography also of help. This is the acute myocardial infarction, whose patient was on one ventilator, stable. Here you can do the myocardial contrast echocardiography with the perfusion studies. What we did a myocardial contrast echo. You can see, look at the flash. First, look at the flash. Waiting for the flash. If you look at the flash, yes, this is the flash, and you see immediately the lateral wall will be filled. But the septal wall is, you can see some contrast, but it is delayed even after 5 or 10 or 20 beats. So that means there is a coronary artery obstruction, but still the myocardium is viable. Same thing you can see even in this flash here. So in this patient, after stable, you can do the PCI, and this patient is likely to improve. That is very, very important. A patient with a STEMI, immediate coronary angiography PCI is recommended, we know, but we have to determine in a non-ST elevation ACS, we know the indication, but one important thing, the echocardiography will help, whether there is a sign, some symptoms of heart failure, whether there is a new or worsening mitral regurgitation. And you must do that to find out what is the LV ejection fraction before undergoing PCI. So to summarize these, echocardiography is very important in the following condition before PCI: acute ST elevation, acute STEMI, acute non-STEMI, angina equivalent, worsening left ventricular LV dysfunction by your serial echocardiogram, signs and symptoms of heart failure, new worsening mitral regurgitation. You have to determine the serial determination of the LV ejection fraction, and of course the issue of the viable myocardium I have addressed. So what to look before PCI? Evaluation of the myocardial wall motion abnormalities, the localization of the infarction, assessment of the infarct site, and another important point we missed is the right ventricular infarction. You have to determine in a case of particularly inferior wall myocardial infarction. Not only that, you have to do hemodynamic assessment of patient with acute myocardial infarction using the Doppler echocardiography. And the complication I have already enumerated. And sometimes in a later stage, you may have to resort to the stress echocardiography before undertaking the PCI. Here is a patient with the acute inferior wall myocardial infarction. You can see the posterior wall is totally akinetic, and you can do, this is the inferior wall. There is a absolutely akinetic inferior wall with the dilated cavity, and you can go into the next stage. You see the RV. RV is also dilated. Free wall is absolutely akinetic, and you go more, you can find there is a moderate tear and of course with the low gradient across the RA and the RV. And if you do the, a subcostal view is very clear that is the free wall of the RV is totally akinetic. And if you do the GLS, DLS is hardly 4 to 5. So that is a definitely RV infarction is associated. So accordingly, before going to PCI, you can plan your management. So during PCI, now that conclude before PCI. Now during PCI, everything is discussed regarding the role of echocardiography before PCI is also relevant during PCI. In addition, what to look? One important thing is the intravascular ultrasonography or IVAS. Very, very important. This is another branch of echocardiography indicated in the percutaneous coronary intervention. What it detects? It detects the atherosclerotic plaque. It assesses the indeterminate lesions. It evaluates the whether it is adequate stent deployment. It determines also the media adventitia interface. It difference of echogenicity in the different parts of the coronary artery lumen can be determined. And not only that, it can identify the features of the plaque composition, whether it is the calcification or the lipid collection, that can be the PCI can be done according to this. So what are the frequent uses of IVAS? And this, to enumerate these, there are important three: assessment of indeterminate lesion, evaluation of the adequate stent deployment, and the proper deployment of drug-eluting stent in critically for reducing thrombus rates. Actually, what happens, why echocardiography is important? Because what are the complications during coronary intervention?
Sir, you have 1 minute.
Sir, I have 1 minute. I have 30 minutes talk.
Sir, due to time constraint, we need to hurry.
So 30 minutes to 15 minutes. I can finish. How can I finish?
Sir, you can continue more 15 minutes.
That's right. If complication of intervention occur in the cath lab, when a patient develops signs of cardiogenic shock and pericardial tamponade after coronary intervention, rapid diagnosis is very, very important. So echocardiography is important. Furthermore, left ventricular function and the regional wall motion can be rapidly assessed. In most instances, particularly under resuscitation, TT is enough, but even we have to resort to T. There are many uses of IVAS, but two fundamental questions a percutaneous interventionist is required. Is a lesion significant and ischemia producing? And therefore, should it be treated? And the second question, has the PCI been optimized? So I'll give an overview of the IVAS, how it looks like during the PCI. So this is a normal artery. This is a three-layer structure. You can read one is intima, this is intima, this is the media, and this is the adventitia. And now, if you find this type of thing, this is actually the fibrous plaque. This is similar to reference adventitia. Then, if you find this type of picture, this is actually attenuated plaque, but there is an absence of calcium due to the lipid pool or the cholesterol crystal, microcalcification, or is a hyalinized fibrous tissue. Calcification, if you sometimes get the calcification, it is also brighter than the adventitia. See, this is the adventitia, but calcification is brighter than adventitia. If you get a relatively scintillating echoes, lobulated or the layered structure, that means you are dealing with the thrombus. Sometimes you may get intramural hematoma, where the internal elastic anemia goes inwards and the external elastic lamina goes outwards, and you may detect the intramural hematoma. And what I called is the age dissection. This is the interface of the adventitia and the media, the presence of false lumen proximal to the stent edges. And you may detect even in the acquired stent malposition, where in the separation of the stent starts from the basal wall with the blood flow. Red arrow is the behind the start, and the yellow behind the start is the yellow. And stent restenosis also you can detect by the echogenic tissue reference to the adventitia. This is the echogenic tissue, and this is the reference to the adventitia. And similar thing can be done by the OCT also. Here I'll give a case. Sorry. this case, you can see 59-year-old men, PCI to LAD and L6 already been done. And when you do the PCI, you can find the L6 is again stenosed. And so it's called in-stent restenosis. So if you do the IVUS in this patient, then you can find out there is an in-stent restenosis, and you can find out where is the proximal part of the stenosis and up to the distal part of the stenosis by the IVUS. And you can find out the proximal part of the stenosis. You go through it and you find the proximal part to the distal part in a similar panel when you proceed to the IVUS catheter, and you can find out everything, and you can find the intima media interface, and you can find out this is the area, and this is the proximal reference, and this is the distal reference. And then you go to the balloon, and when you go to the balloon, you can balloon it, and during ballooning, you can find out also how much balloon is required to find the desired diameter of the coronary arteries, and you can find out that this is the before and this is the after, and this is the before and this is the after, both proximal and the distals. And when you put the after and dye, you can find out the beautiful flow, almost a TIMI3 flow in this. So this is during PCI. Now a few minutes after PCI. After PCI, the post-catheter electrophysiological laboratory complication. There are various complications of pericardial tamponade, ventricular failure, cardiogenic shock, intramural dissecting hematoma, occlusion of the coronary stent, and displacement of the implanted device. Where you can, here is a story of acute mitral regurgitation of the inferior wall. The post-implant, you have to find out whether there is a adequate thing is done or not by finding several parameters, of which one is the importance, the mitral regurgitation. If you find the inferior wall after PCI, there is a gross mitral regurgitation. That means the PCI may be done well. There may be some papillary muscle dysfunction or something we are missing. Then sometimes you may perforate and you can land in pericardial tamponade. Even with a small amount, you can see the clot inside, and this is very, very important because delayed cardiac tamponade may occur, must be considered as a cause of late hypotension after PCI. Then you can have an inferior wall myocardial infarction after PCI, these sort of similar things of pericardial tamponade in this patient. So it has to be detected by echocardiography. Of course, certain aneurysm can be detected during PCI, and you can find out the pericardial tamponade if you rupture the top of the aneurysm. And here is a patient, even after PCI, you can find the intramural dissecting hematoma. Here is the intramural dissecting hematoma, and that can be seen even after PCI. But interesting thing that after 10 days, when you do the repeat echo with the contrast echocardiogram, that hematoma becomes subsided, even spontaneously. That can also happen. So certain facts I'll give you within a few minutes. The certain fact, the post-PCI important observation. Very important is the stress echocardiography is very, very important for the risk stratification, because we know the patient with the negative stress is low risk, but if it is inconclusive results are at a higher risk. That is very, very important in the stress echocardiography. Even if you can do the intravenous myocardial contrast echocardiography, the perfusion study I have shown is an emerging technology, because the no reflow phenomenon is a continuing challenge in the cardiology, because you have to show the TIMI3 flow. If you know the TIMI 0 to 2 flow is associated with the poor recovery of the contractile function, if the TIMI3 flow is associated with the good recovery. That is very important. Then, because the cause is that multiple mechanisms, because the microvascular disruption, endothelial, the myocardial edema, neutrophilic infiltration, obstruction by the thromboembolic debris may be involved after PCI. And the preserved microvascular integrity by MC does not always translate into recovery. That has to be kept in mind. But absent perfusion has a high predictive value for low recovery and may identify patients with requiring further management. And as in this case, this is a picture taken from the in a associated myocardial infarction. You can see there's a good recovery, and in this case is not a good recovery. Another important area is the myocardial work after PCI. That is a very new emerging technique is come, and that you can assess the prognosis of the patient. I'll see a patient with the two, you can see this is the inferior myocardial infarction with a GLS of -11, but these are the area of the myocardial work is definitely less, and both you can in the work efficiency and also in the work wasted work. And this is the good area you can find out. The beautiful graph is the global average, but in the low, these area particularly, you can see the graph is definitely bad. If you sum up this, how much you can sum up with the how much is the wasted index and how much is the efficiency index, that you can do the global work in myocardial work efficiency. Another important after PCI is RV function and the RV stream, that and LS stream. That is very, very important in prognosticating the post-PCI prosmosis. Then mitral regurgitation and the diastolic dysfunction is also very, very important to assess in the post-PCI case. Then is the LV longitudinal strain and strain rate, because it can give within 48 hours, even if you give a good prognosis whether your PCI has been correct or not. See, there is a case where before the PCI, this is the after PCI, and this is done only after the 48 hours. And you can find out the excellent improvement so far the global longitudinal strain is concerned. I told you the left ventricular thrombus is a very important event. See, the prognosis of patient with the LVT did not improve even if the LVT is regressed. So LVD was like a generalized indicator of impaired cardiac formation rather than the cause. So left ventricular thrombus is very, very important. I have already important of the stress echocardiography. So I'll finish a very important case. Is a 55-year-old man presented with the acute chest pain for the last 3 to 4 days. Cardiac enzymes are high and evidence of non-stem infarct infralateral wall in the ECG. Echocardiogram akinetic infraposterior and the lateral walls in the mid and basal region. The LVF is only 45% with the grade 1 MRTR, with a mild elevation of the pulmonary artery pressure. Coronary angiography, the tight listen the circumference, actually other coronaries are normal. Here this patient, the PCI has been done, and patient reports symptom-free for 48 hours. Third postoperative, the patient contact sudden abdominal distension and the vomiting. Jugular pressure elevated, but ECG did not show any significant change. Immediately, the patient was shifted to CCU and urgent echocardiography is performed, and you find the free wall rupture. You can see when I put the probe, there is a heart is hardly any moving. This is surrounded by the large pericardial hemopericardium with the clot. And when you put the color, you can find the free flow in the lateral wall with the rupture of the lateral wall. And you can see the here is first happens is the intramural dissecting hematoma and ultimately leading to the rupture. You can see the rupture. You can see the rupture with the to and fro. So this is a cardiac rupture. This patient was immediately shifted to the cardiothoracic OT, but before undertaking any intervention, patient developed cardiac arrest within 20 minutes, and CPR failed to resuscitate the patient, and we lost the patient. So cardiac rupture is a very, very important. Even it can happen in the 15% of the legend. Here is one thing I like to tell. One important 30 seconds is a common cause is a spontaneous rupture, but sometimes the cause of cardiac rupture is thought to be a small branch of the left circumflex artery, which was occluded during PCI. Who knows that happens in our patient? This is one of the rare but important mechanism of cardiac tamponade after PCI. So points to my finishing slide. Echocardiography is an accurate tool for the evaluation of patient with a known or suspected coronary artery disease. Echocardiography is a versatile imaging modality for the management of patient with the chest pain and assessment of left ventricular systolic function, diastolic function, and even myocardial and the coronary perfusion, and is therefore useful in the diagnosis and triage of patient with the acute chest pain or dyspnea. Echocardiography is a non-invasive diagnosis which provides information regarding the cardiac function and the hemodynamics. It is the most frequently used cardiovascular diagnostic test after electrocardiography and the chest X-ray. However, in a patient with the acute chest pain, transthoracic echocardiography is essential both for diagnosing acute coronary syndrome, zeroing on the evaluation of the ventricular function, and the presence of regional wall motion abnormality, and for ruling out other etiologies of acute chest pain or dyspnea, including aortic dissection and the pericardial effusion. Thank you.
Thank you, Dr. Aniruddha for his professional quality of presentation regarding the role of echocardiography in Parkinson's coronary intervention.
So can we switch one to third speaker, Dr. Manish Banshal? He is the Director, Clinical and Preventive Cardiology, Medanta Heart Institute, India. His topic is overview of 3D echocardiography and its importance in intervention. Please, sir, can you hear us, sir? Dr. Manish Banshal? So by the time Dr. Manish Banshal get ready, we can discuss about the first speaker topic. I request panelists, do you have any question to the speaker? Then you can ask or discuss about this topic.
Thank you, Nilüfer. I'm Professor Mustafa Zaman. I'm actually the role of echocardiography in PCI by Dr. Aniruddha. That was excellent presentation, and a lot of things I actually have discussed and everything. But my opinion, especially for the emerging cardiologists, always before I already have mentioned that to do the echocardiography before angiography or PCI. This is very, very important because of you could not miss the any LV function. RV function is very, very important, and MR, AR, even in case of acute case, you do not miss the septal rupture also, and any especially for any perforation after the PCI, the perforation is you can detect. And so everybody should do the echocardiography before and after also very important, because if you use the low molecular weight heparin, you can judge whether it will start low molecular weight heparin or not, because there may be a chance of perforation or any rupture. So you can do. And another things I want to discuss, I have a question to the Honorable. There is very, very little scope to assess the by echocardiography the ostial stenosis, because it do not never we use during before PCI. The by echocardiography ostial stenosis is very, very important, and this is my question to. And the microvascular dysfunction, this is very difficult because by angiography we can see only 5% of the coronary tree, but without this is the very difficult to assess the microvascular dysfunction. So this is two questions. And another system that's by LV mass before PCI, we can assess only transthoracic whether patient will benefit it or not. So this is for the emerging cardiologists who will do a PCI. So my two questions to you, one is microvascular dysfunction, another is actually late main ostial or any ostial disease, RC ostial by echocardiography. And another one I want to say, you also mentioned very nicely that diastolic dysfunction is very, very important in case of acute myocardial infarction. That is when we do the primary PCI. Always the diastolic dysfunction is changes before systolic dysfunction. So after PCI, primary PCI, the diastolic dysfunction may be reversed, maybe this is possible also. So this is very important also. So everything you have discussed, but a lot of things you've discussed, the special things may be missed by suddenly. So this is my question to you.
Thank you, sir.
And another about microvascular dysfunction and ostial disease. Can you assess?
Thank you, sir. Sir, we Dr. Manish Banshal is ready. So we are going for the next speaker. Yeah. So overview of the 3D echocardiography and its importance in intervention. I request Dr. Manish Banshal, please present your lecture. Thank you, sir.
Okay. Good afternoon, everyone. First of all, I thank the Bangladesh Echo Society and the organizing team of this meeting for giving me the opportunity to participate in this important session. So as we are aware, there has been almost an explosion in the field of structural heart disease interventions in the last 10-15 years because of the advancements in technology. And this change has also given birth to a new stream in echocardiography, that is interventional echocardiography, because echo is pivotal in this the entire process of structural heart disease interventions. So we know that for pre-procedure planning, there is no competition to echo. Echo is the modality which which gives us the diagnosis for which we embark upon doing the intervention. Echo is also the most important modality for post-procedure assessment and follow-up because of its simplicity and ease of use. But importantly, echo has also become very important for intra-procedure guidance. The reason is that unlike coronary arteries, valves and soft tissues of the heart are not seen in fluoroscopy. So we need imaging guidance, and for that, TEE is the ideal modality to guide the procedure. So unless we have some anatomic landmark like heavily calcified aortic annulus, which is usually there in patients who are undergoing TAVI, for most other procedures, echo is indispensable for guiding the procedure. Now, the main role of echo during the actual procedure is to provide spatial orientation and to guide the path of various devices and the catheters and the implants which are going to be put. 3D becomes very useful because there is no other modality which could give such good spatial orientation and display of the cardiac anatomy as 3D echocardiography. So 3D TE plays a very important role, especially for mitral valve lesions, which are best visualized by 3D TE. And the 3D is also very helpful because interventionists who's going to do the procedure, for interventionists, interpreting 2D images may be more challenging because they are not that used to of seeing those images. But 3D is much easier to interpret. So 3D, for all these reasons, plays an important role, although 2D TE remains the main modality even during the procedure. So I'm going to show you some examples where 3D has played a very important role in guiding the procedure. But before that, there are two main modalities, modes of TE that we use 3D TE for intra-procedure guidance. One is biplane imaging, simultaneous, which provides us two 2D images side by side. The relative angle between these two can be modified, and the other is 3D and fast view, which we use intermittently. 3D in fast view provides complete spatial orientation, but the image quality is generally poorer as compared to 2D, and frame rate is also low. Therefore, 2D biplane or just plain simple 2D TE is the main modality with intermittent 3D TE. So I'll show you some examples. First is paravalvular leak closure. So paravalvular leak is one of the very common problems after valve surgery, and it is actually the second most common cause for reoperation. But reoperation for this purpose is challenging because most of the patients present within first year of their surgery, and doing surgery that early after initial surgery is not going to be easily acceptable, neither for the patient nor for the surgeon. And therefore, paravalvular leak closure by device becomes natural choice. So in such patients, we have to do a pre-procedure assessment for defining the number of defects which are present, the location, the size, shape, prosthetic heart valve function, and other associated anomalies which may be relevant for planning the procedure. And then during the procedure, the whole procedure is performed under echo guidance. So here is an example. This patient has paravalvular leak closure around the mitral valve. So as we can see here in 0-degree view, there is a jet origins seen, and then we are able to see jet origin in 79-degree view also. But from these images, it becomes very difficult to make out how many defects are there, where exactly they are situated. 0-degree image gives an impression that it is medial defect. 79-degree image gives impression that it is a posterior defect. But if we switch on 3D, it becomes immediately clear that there is a defect which is in the region of around 1 to 2 o'clock, and it is a large defect. And not only we can locate the defect, we can also quantify we can assess the shape and we can measure the dimensions. If we use only 2D, we will be able to measure only the diameter of the defect, but 3D will tell us the total dimension, length, and shape which is required for planning the procedure. This is another patient, again has paravalvular leak closure around the mitral valve. And once again, from these images, 2D images, it is difficult to make out the number and location of the defects, but 3D TE shows us that there are two defects. One bigger defect is in the region around 6 o'clock position, and the smaller defect is in the region of 2 o'clock. So once it is decided that the paravalvular leak closure is to be done, then this procedure will be done. For mitral valve, the procedure is done via venous access, and for that, interatrial septum needs to be crossed. So precise location of septal puncture is also very important, not only for this procedure, but for almost all procedures related to mitral valve and for left atrial appendage occlusion. If we don't do septal puncture in the proper position, it can lead to a lot of problems during the subsequent procedure. So for this 3D TE biplane imaging is very helpful. We use bicable imaging and short axis views simultaneously to decide where we want to do septal puncture. So here we have two examples. In this, there is mid fossa puncture, and here we have posterior puncture. If you want to do LA appendage occlusion, this is going to be ideal. If we do puncture here, we may not be able to do LA appendage occlusion via this route. So it's very important. Now, once septal puncture is done, the next step is to cross the defect, which actually is the most challenging step in paravalvular leak closure, and it is often very frustrating also because it is totally blind and we have to blindly guide the wire through the defect. Fluoroscopy can give us some idea, but it is not that easy. So here I have an example where 3D was really very helpful. So as we can see, this patient has a defect which is close to the interatrial septum. We can see it better in 3D image. So this is the defect here. This is the mitral valve, and here we have interatrial septum. So we have to go very close to the septum. So when the septal puncture was done and the sheath was advanced, the sheath was pointing like this. And if from this position we advance the wire, we will be going towards the LA free wall or LA appendage, but we want to come here. So how we can do that? So one option would be to advance the wire, make a loop, and then bring it like this. So which is what was done in this example. So a loop was made. But then after we reached close to the orifice of the defect, the next step was to turn the wire towards the left ventricle so that it could cross the defect. But in spite of a lot of efforts, this could not be done. And it at one point of time, it became very, it appeared as if we would have to abandon the procedure. But then we decided to withdraw the sheath and flex it here itself like this and try to cross in this position. But interventionist was worried that if he withdrew the sheath very close to the septum, he might come out of the left atrium. So this whole thing was done in 3D guidance. So as we can see, as sheath has been withdrawn and it has been flexed towards the defect, and now the sheath tip is directly pointing towards the defect. It is almost on top of the defect. So it was very easy to cross the defect now after this. As we can see here, wire is going through the defect and the plug has been put in. So this procedure became possible only because of 3D guidance. Now, another example here, this patient had two defects, one here and the other one is the smaller defect here. So first this defect was closed, which was not difficult at all. But after that, for closing this defect, we had to cross into the left ventricle once again. And in fluoroscopy, it becomes very difficult to make out where the defect is and when the wire is going through the defect, whether it is going through the same defect around the device or it is going through the defect that we want to cross now. So once again, 3D was very helpful. As we can see here, this is the first device and this is the second defect which is being closed. And we can very clearly see that the guide wire is going through this defect. So with this confidence, the interventionist can proceed with deployment of the device. And this is the final image. We can see two devices around the mitral prosthetic valve, and the defects were closed successfully, as we can see here in this. So there are a number of examples of paravalvular device closure where 3D proved useful and continues to be very useful. Now, apart from PVL closure, which is actually not a new procedure, it's been there for many years. There are so many other mitral valve interventions which have become available now, and some have become established treatment for various valve lesions, particularly mitral clip. So mitral clip is a procedure which is done for secondary or degenerative mitral regurgitation. In this procedure, a clip is placed at the tips of the mitral leaflets to almost fuse them together, so that the mitral orifice, which is single orifice valve, becomes double orifice valve, and the mitral regurgitation is taken care of. So this procedure is done completely under fluoroscopy and echo guidance, TE. Without echo, this procedure cannot be done. So this is one example. This patient had flail PML with eccentric severe MR. As we can see here, PML is flail and there is massive MR. More images, and 3D shows that this was a P2 flail. So Dr. Burkule in the morning had shown steps of mitral clip procedure. I won't go into those details, but briefly I would mention that clip alignment is of paramount importance in this procedure. And for that we use biplane imaging. This is LVOT view, which tells us whether clip is anterior or posterior or central in relation to the mitral orifice. It needs to be absolutely in central position. And this is bicommissural view, which tells us whether it is medial, lateral, central, or medial. This will depend on the site of the jet origin. We want to be exactly at the site from where the jet is originating. And at the same time, we have to also ensure that clip is perpendicular to the coaptation line. So for this, 3D and fast view is used. So here in this is the coaptation line, and as we can see, this clip is not perpendicular, so this needs to be realigned. And after realignment and repeated confirmation that we are through the jet absolutely central and clip is properly aligned, clip is deployed. So as we can see here, this MR, which was severe, almost torrential, is completely eliminated. And here we have double orifice mitral valve after deployment. This is another example. So in this patient, this was secondary MR. Clipping was done. When the clip was positioned, it appeared everything appeared to be very good. This is double orifice valve here. There was no MR. But when clip was deployed, somehow AML came off. And as we can see, the clip is now hanging only on the PML. So another clip had to be deployed just lateral to this. So this again became possible only because of 3D. So as we can see here, this is the original clip, and this is the second clip, which is holding together both AML and PML. And because of this, I mean, after deployment of this second clip, MR completely disappeared, and there was no significant gradient. Apart from mitral valve, there are so many interventions being developed for tricuspid valve also. We have a clip similar to mitral clip for tricuspid valve also. There are so many other procedures. All of this again require echo guidance, particularly 3D TE, which is again very helpful in defining the anatomy of the defect, the valves, leaflets, device position, location, and all those things. So to summarize, structural heart disease interventions are becoming increasingly common. The scope is widening because of ongoing advancements in technology. 3D TE is indispensable in guiding many of these interventional procedures, especially those related to the mitral valve, and now tricuspid valve as well. Thank you so much.
Thank you, sir, for your excellent presentation on overview of 3D echocardiography and its importance in intervention. So I'd like to ask the panelists, if you have any question to the speakers, you can ask. or yeah, Mustafa Zaman sir asked a question to Dr. Anuruddha De. Can you just respond to his
Yes.
question?
Yes,
Thank you.
Nilüfer, I'm responding. The three questions, in fact, the first is whether we can detect by echocardiography any ostial stenosis or not. Of course, we can detect if the window is good, and we can like to see particularly and the focus on the ostium, and then we can detect, of course, the ostial stenosis. Even the flow, gradient, everything can be determined, no problem. There's a lack of time. I have a lot of slides, but I could not show it. Second thing is a very, very important that I have already touched it. That is regarding the small vessel defect. Yes, these are there. Here is the importance of the myocardial contrast perfusion scanning that I've showed already in one important case in the before even going to see the viability. And in fact, it can be done even the post PCI. And this modality is coming very good to find out the perfusion after the PCI. Even it can be done before PCI, and it can be done even after PCI. So in both the cases, it gives a fairly good important things. In the before PCI is the viability, and after PCI, it will give you the prognosis. And third is that your question was whether the LV clot can be detected only by the TT or the TEC. LV clot, majority of the case, in 95% of the cases, can be detected only by the transthoracic. You may not have to do the transesophageal echocardiography. Of course, in certain cases, you may have to resort to. Even if you were in doubt, particularly the LV clot in the apical region, here again, the LV opacification by the contrast echocardiography, again, very helpful to find out there is a clot or not.
Thank you, sir. I would like to ask the chairperson, Professor Qamrul Islam, sir, to conclude the session, as it is a Friday and we have prayer, so we are not taking any more questions.
Nowadays, echo has tremendously improved. All the speakers, especially Dr. Anuruddha and Dr. Manish Banshal, nicely elaborated the role of echo in intervention before, during, and post. So, and one I always myself follow, and I always tell my